Testing 1 2 3. Test 1 2 3. Test 1 2 3. 1 2 3. They're ready. I mean, you're ready. Make sure that your overhead mic's on. That one. Just hold that little button down on top of that turn screen.
Have it on.
Just stand the egg.
Here? Right here. Good afternoon, and thank you for the invitation to serve as the speaker for this visiting professorship program. I'm going to bring to you today some current research and emerging therapies in psoriasis and psoriatic arthritis. These are my disclosures and disclosures for this talk. As many of you know, psoriasis is a common disease in the United States, affecting more than 7 million US adults, which makes it for about 2% prevalence among all US population over the age of 20. It typically occurs between ages of 15 to 35, but people of any age can be affected. Its hallmark is raised red scaly papules and plaques, which can be itchy and or painful. Importantly, up to 30% of patients with psoriasis have or will develop psoriatic arthritis during their lifetime. Psoriasis is not just a skin disease. Psoriasis can cause significant morbidity and mortality, and patients with severe psoriasis have increased risk not only of overall mortality but also of cardiovascular mortality. There are many coexistent illnesses that can occur in patients with psoriasis, including myocardial infarction and other cardiovascular disease such as stroke and atherosclerosis, renal disease, cancer and liver disease, dementia, diabetes and metabolic syndrome, as well as depression, and these patients have also increased suicide risk. Cutaneous T-cell lymphoma can also occur in patients with psoriasis. There are many ways in which physicians and investigators assess severity of psoriasis, and one such way is by the proportion of the body surface area that is involved in these patients. In a patient that has less than 3% of body surface area involved is said to have mild psoriasis, while those who have more than 10% of area involved are defined to have severe psoriasis. In a recent study from the UK, which enrolled patients with severe psoriasis, so those patients who had more than 10% of their body area involved, found that these patients with severe psoriasis have twice higher risk of death at 4 years compared to general population. In addition, patients with severe psoriasis die approximately 4 to 5 years younger than they otherwise would based on their risk factors for death. This slide presents the risk of mortality and cardiovascular disease in psoriasis. The patients with psoriasis have about 50% increased risk of cardiovascular mortality, and as you can see in this slide, in yellow you have patients with severe psoriasis as defined by need to take systemic therapies, and in green or blue are patients that have no psoriasis. And you can see that the mean age at death in patients with severe psoriasis is about 5 years less than those than the controls. The most common cause of death in psoriasis is cardiovascular disease, with a 50% increase in the risk of MI, stroke, cardiovascular disease mortality, as well as a 50% increase in the risk of major adverse cardiovascular events. Some studies have shown that patients treated for severe psoriasis with systemic therapies are 30 times more likely to experience major adverse cardiovascular events attributable to psoriasis than to develop melanoma. We know now that the immune system is abnormal in psoriasis, and that active lesions of psoriasis represent active inflammation. The more skin area involved, the more inflammation a patient has. And there is a lot of data suggesting that psoriasis severity is associated with levels of various markers of systemic inflammation, including C-reactive protein, the integrin ICAM1, serum amyloid A, as well as the cytokines on the Th1 and Th17 pathways. The unifying theory nowadays is that the inflammation may be a common pathway between psoriasis and other diseases, including atherosclerosis, obesity, insulin resistance, and metabolic syndrome. So what can clinicians do in order to improve outcomes for patients with psoriasis? First of all, it's important to screen for comorbidities, and especially important to screen and manage regular or usual cardiovascular disease risk factors, including smoking, diabetes, hypertension, and hyperlipidemia. Secondly, treating psoriasis to decrease inflammation is important in order to improve outcomes in patients with psoriasis in the long run. There are some studies that have shown that systemic therapy, including TNF blockers, as well as phototherapy, is associated with less myocardial infarction. So as you can see in this slide, those patients who were taking TNF blockers compared to topical agents, there was about 50% decrease in myocardial infarction rate ratio. You can see that there was not much of a difference between those patients who were taking TNF blockers versus those that were taking oral agents or phototherapy. Recently, Wu and his collaborators published in the Journal of American Academy of Dermatology a study in which they looked at the cardiovascular risk measured by the rates of developing major adverse cardiovascular events, which include myocardial infarction, stroke, transient ischemic attack, or unstable angina requiring hospitalization. They included in this study patients that were 18 years of age or older and who had two diagnoses or two claims for psoriasis over the observation period, with at least one diagnosis of psoriasis in the preceding 6 months prior to the enrollment in the cohort. And they compared two types of medications, TNF blockers and methotrexate. And what they found, as you can see in this graph, is that at every time point, the rate of MACE, so the major adverse cardiovascular events, were higher in patients taking methotrexate compared to the patients taking TNF blockers, and this was statistically significant. In our group, we did something similar, looking at the Medicare claim data and using a composite cardiovascular disease index, as well as a MICE and stroke as our outcomes. And what we found is that the MI rates were highest for methotrexate at about 10 over 1,000 patient years. However, after adjusting for age, sex, comorbidities, we did not find any significant difference between systemic therapies such as methotrexate or various TNF blockers for any of the outcomes studied. So what should we do regarding aggressive treatment for psoriasis? Well, the short answer is we don't know yet. We don't know whether we should treat these patients aggressively or not. Probably the best answer is that more research is needed. What we need to figure out is whether the TNF blockers have independent effect on cardiovascular disease, or whether the cardiovascular disease risk is decreased by the TNF blockers controlling psoriasis or inflammation better. Another important comorbidity in psoriasis is depression, with about a third of patients with psoriasis having concomitant depression. And it is currently thought that the inflammatory cytokines may play a role in both these diseases. It is an understatement to say that depression affects quality of life and survival. And unfortunately, depression is undertreated in patients with psoriasis. And what is different in patients with psoriasis compared to patients with other skin diseases is that these patients have increased risk for committing suicide and suicidal ideation. For example, a study has shown that suicidal ideation in the prior 2 weeks was as high as 10% in patients with psoriasis. In addition, suicidal ideation puts the patients with psoriasis at at risk for near-term self-harm. The increased risk of depression and self-harm in patients with psoriasis is associated with a mix of biological inflammatory factors as well as self-image and other quality of life related factors. Some have suggested that achieving 100% or near 100% skin clearance for patients with psoriasis can mitigate depression risk and improve quality of life. And this is data suggesting that, in fact, this is right. So if a way of measuring severity of psoriasis and disease activity in psoriasis is using this PASI scores. The higher the PASI score, the higher the improvement. So, for example, a PASI 75 means 75% improvement for baseline, while a PASI 90 is a 90% improvement from baseline. A way to measure quality of life from the perspective of dermatologists is so-called the Dermatology Quality of Life Index. And a response of 0 to 1 on the Dermatology Quality of Life Index means that the respective skin problem has no effect at all on patient's life. So this was data from a clinical trial of a biologic, and what it showed is that patients that achieve 75% improvement, so a score of PASI 75, have about 40% probability of achieving DLQI of 0 to 1 response. While if a patient achieves about PASI 90 or a 90% improvement for baseline, this leads to an increase to like a 60% probability of achieving a 0 to 1 DLQI response, suggesting that better skin clearance results in a better quality of life. There are many biologics currently approved to treat psoriasis. Those include biologics that affect the TNF pathways, the IL-12 and IL-23 pathways, and more recently the IL-17 pathways. The most long-term data exists for TNF blockers, and the ustekinumab, the IL-12/23 inhibitor, has now emerging to have long-term data as well. There are some differences in the usage of this medication depending on other comorbidities that a patient may have. So, for example, if a patient has inflammatory bowel disease, the two biologics or TNF biologics that can be used are adalimumab and infliximab. The ustekinumab is approved only for for treatment of Crohn's disease as well, while the IL-17 biologics have a warning with possibility of developing flares of inflammatory bowel disease. The warning on the TNF blockers regarding the development of congestive heart failure and multiple sclerosis is long-standing now. But interestingly, the IL-17 blockers have shown favorable results in phase 2 studies for the treatment of multiple sclerosis. In terms of administration, the frequency of administration affects long-term persistence of a patient on a treatment. So the ustekinumab, which after a loading dose is administered every 12 weeks, has quite good data for long-term persistence. As I mentioned at the beginning of the talk, about 30% of patients with psoriasis also have psoriatic arthritis. And the disease activity in one disease, so in psoriasis, does not follow disease activity in the other manifestations. So for example, in psoriatic arthritis. Thus, we have patients that can have limited psoriasis and mild arthritis, and who can, or other patients that have extensive psoriasis and severe arthritis. And I'm going to move now into how we currently diagnose and manage psoriatic arthritis. Psoriatic arthritis is a seronegative spondyloarthropathy and is a very highly heterogeneous disorder. It can present with many symptoms and signs, including enthesitis, which is inflammation of the entheses, so the insertions of tendons and ligaments on the bone. It can present with peripheral arthritis. It can present with dactylitis, which is swelling of the toes or digits. There are nail manifestations in psoriasis and psoriatic arthritis, and also can have axial disease, and similarly to psoriasis can also have a suite of coexistent illnesses or comorbidities. As I mentioned, psoriatic arthritis is classified among the spondyloarthritis. Other diseases part of this family include the reactive arthritis. The prototype is ankylosing spondylitis. And then there is arthritis associated with inflammatory bowel disease, such as Crohn's disease and ulcerative colitis, also called enteropathic arthritis. Psoriatic arthritis, similarly to other inflammatory arthritis, such as rheumatoid arthritis, can cause permanent joint damage, severe disability, and poor health-related quality of life. The prevalence of psoriatic arthritis is about 8 to 30% in patients with psoriasis, and it affects up to 2 in 1,000 US adults. It affects both men and women equally, and it's most commonly diagnosed in adults of 30 to 50 years of age. About 60% of the patients who develop psoriatic arthritis develop psoriasis first, but about a quarter of them develop both diseases at the same time. And in about 15% of the patients, the psoriatic arthritis is diagnosed first. Risk factors for the development of psoriatic arthritis are severe psoriasis, nail disease, HIV, as well as obesity and smoking. This slide shows a few clinical characteristics of psoriatic arthritis. One is peripheral arthritis. And what is different in psoriatic arthritis compared to rheumatoid arthritis is that the inflammatory arthritis is typically asymmetric and involving what we call rays. So it can involve both the proximal interphalangeal joints and the metacarpal phalangeal joints, but also the distal interphalangeal joint of the same finger. And you can see here the left hand is not involved. This image presents enthesitis, so inflammation at the insertion of the Achilles tendons on the calcaneus. And this image shows nail dystrophy, but also what we call sausage fingers, sausage toes, the medical term being dactylitis. So what dactylitis is inflammation in the synovium, the tendon, and the surrounding structures of a toe in this case, or a finger. Psoriatic arthritis is one of those arthritis that involve the distal interphalangeal joints, and it has to be differentiated from osteoarthritis, gout, or multicentric reticulohistiocytosis. And the last disease that I mentioned is basically arthritis of the involves the distal interphalangeal joints, and also the patients have a specific rash over around the nail and over the DIPs. It's even it's hard to differentiate psoriatic arthritis sometimes from other diseases, especially when some of these diseases appear concomitantly with psoriatic arthritis. In this study that included adults involved in the health professional follow-up study and the nurses' health study, the investigators found that those participants that had psoriasis, both psoriasis and psoriatic arthritis, had about 5 times higher risk for also having gout compared to participants that had no psoriasis. I put this here just to remind everyone about the CASPAR criteria for classifying psoriatic arthritis, which basically define a patient as having psoriatic arthritis for clinical trial purposes when they have an inflammatory musculoskeletal disease that includes arthritis, spondylitis, involvement of the spine, or enthesitis, and who also meet about 3 points out of this table. So they, based on the presence of psoriasis, of nail dystrophy related to psoriasis, on being serologically negative, so that means negative rheumatoid factor, or having dactylitis, and who another point is given for the radiographic presence of juxta-articular new bone formation, which is among the inflammatory arthritis, it's something that is quite specific for the seronegative spondyloarthropathies like psoriatic arthritis. This quite busy slide shows the differences or the factors that we looked at when trying to differentiate between a seronegative spondyloarthritis like psoriatic arthritis and another very common inflammatory arthritis, rheumatoid arthritis. So as I mentioned before, while patients with rheumatoid arthritis have symmetric involvement. So that means the similar joints or similar joint levels involved on both sides of the body. Patients with psoriatic arthritis, in patients with psoriatic arthritis, the joint involvement is usually asymmetric. Psoriatic arthritis can be both, can be either mono or oligo or polyarticular, while rheumatoid arthritis is primarily polyarticular. We discussed a little bit about the involvement, about the presence of enthesitis and dactylitis as a common feature of psoriatic arthritis. The spine, which is largely spared in rheumatoid arthritis, except the cervical spine, can be involved in psoriatic arthritis, and it represents the axial involvement of psoriatic arthritis. And sacroiliac joints can also be involved in psoriatic arthritis. Both diseases are erosive and cause deformities. And as I mentioned just a little bit ago, psoriatic arthritis has new bone formation, while in rheumatoid arthritis there is just bone loss and no new bone formation. The genetic associated factors are a little bit different, and in general, patients with psoriatic arthritis do not have positive tests for rheumatoid factor or anti-CCP testing. Rheumatoid arthritis primarily affects women more than men, while there is equal involvement, a 1-to-1 male-to-female ratio in psoriatic arthritis. Extraarticular manifestations of psoriatic arthritis include inflammatory bowel disease, eye involvement with uveitis and dry eye syndrome or Sjogren's disease. And similar to psoriasis and rheumatoid arthritis, there are common comorbidities occurring in patients with psoriatic arthritis, including diabetes, cardiovascular disease, fatty liver disease, and obesity, as well as depression, anxiety, and chronic kidney disease. Other more severe ophthalmic disease, such as scleromalacia perforans, that is represented in this slide, can also occur in patients with psoriatic arthritis. Myocardial infarction is a common comorbidity in psoriatic arthritis, with patients who have severe psoriasis having 30% increased risk compared to those who do not. To compare that with rheumatoid arthritis, the risk for MI is somewhat lower, because in rheumatoid arthritis the risk is twice as much. There are many factors that influence comorbidities in these patients, including lifestyle factors such as obesity and smoking, psychosocial such as social support, inflammation and treatment, so whether the inflammation is controlled through the treatment, and all these affect the treatment for comorbidities in psoriatic arthritis. This slide shows recent data that showed that comorbidities are diagnosed in patients with psoriasis about 3 to 5 years sooner than the psoriatic arthritis itself. And it seems that at about the time when comorbidities are diagnosed, the healthcare-related costs increase, followed by a sharp decline and a moment of diagnosing psoriatic arthritis, likely because of controlling the disease or the inflammation better. The IL-23 and the IL-17 are thought to play a very important role in psoriatic arthritis, with them being sort of central managers, if you will, of the inflammation, of activating TNF, IL-6 and IL-1 pathways. They also participate in osteoclast and osteoblast activation, and that result in erosions from the osteoclast activation and new bone formation through the osteoblast activation. This busy slide shows that we have a lot of options currently for both psoriatic arthritis and psoriasis. And the colors, so in pink or magenta, are the old traditional disease-modifying agents, methotrexate, leflunomide, and sulfasalazine, which actually do not have an FDA indication for either psoriasis or psoriatic arthritis, but which have been used successfully over the years, and certainly their use has not necessarily diminished since the biologics came on board. Then in blue are the TNF blockers, with the first three being approved for treatment of both the skin and manifestations and the joint manifestations. The certolizumab is being considered for approval now for psoriatic arthritis, for psoriasis. It has been approved for psoriatic arthritis for some time. Ustekinumab is the IL-12, IL-23 blocker. And as I mentioned a little bit earlier, there is emerging data of the long-term benefit of this medication. And alpremilast is an oral medication, a phosphodiesterase 4 inhibitor that is approved for both psoriatic arthritis and psoriasis, and there is some benefit for dactylitis. Then in the lighter blue here, there are the IL-17 blockers. The only IL-17 blocker approved only for psoriasis is brodalumab. And then the newer medications that are inhibitors of only the IL-23, guselkumab, that's approved in psoriasis, and it's in development for psoriatic arthritis. Tofacitinib, which has been used successfully in rheumatoid arthritis for a long time, has recently been approved for psoriatic arthritis as well. This is how our psoriatic arthritis treatment toolbox looks nowadays. I still have here non-steroidal anti-inflammatory agents and glucocorticoids, and then adjunct therapies such as physical therapy and occupational therapy, exercise and weight loss, and dietary changes to control comorbidities such as obesity and metabolic syndrome, social support and talk therapy or cognitive behavior therapy for help with a depression. This is a somewhat older treatment algorithm for psoriatic arthritis based on the 2015 GRAPPA guidelines. The American College of Rheumatology at their annual meeting last year in San Diego have drafted a new guideline which is similar to this one, except that the biologics are preferred now to oral agents. Of course, patient preference plays a very important role in the choice of therapy and what should be done next for these patients. This busy slide that was part of the GRAPPA guidelines for psoriatic arthritis basically shows at the top the various medications that have been used in psoriatic arthritis. You can see that some medications are missing because they were not approved at that time. The C in red here basically means that caution was advised. So for example, for non-steroidal inflammatory, for patients who have cardiovascular disease, non-steroidal anti-inflammatory drugs need to be used with caution. In blue, with a question mark, it is represented the fact that there is some data suggesting potential harm, and that's, for example, for glucocorticoids, again, in the patients with cardiovascular disease. The P in green represent the treatments that are as preferred interventions for uveitis. For example, the glucocorticoids, adalimumab and infliximab are the agents that are preferred. And in yellow, yellow boxes represent are used to represent need for monitoring. So for example, in a patient with HIV, if they are placed on a TNF blocker, such as etanercept or adalimumab or infliximab, they may need to be monitored more carefully for potential infections, including opportunistic infections. The treat-to-target principles and paradigm have moved into psoriatic arthritis after first being tried out in rheumatoid arthritis. The idea of this strategy is that together with the patient, the physician should select a target and objectively monitor the disease, follow up on changes, and modifying the treatment in order to get to the target. Similar to rheumatoid arthritis, the disease activity can be objectively measured using several instruments. One of those is the minimal disease activity, or MDA, which basically takes in consideration whether or not a patient meets 5 out of the 7 criteria. Disease activity in psoriatic arthritis, or DAPSA, is similar to the clinical disease activity index in rheumatoid arthritis, except that the tender joints count score and swollen joint count score are done in more joints, and it also includes CRP level. So there are many symptoms that define an exacerbation of psoriatic arthritis or a flare. There can be, a patient can experience physical symptoms such as joint pain, swelling, or their previous affected area of psoriasis or new psoriatic plaques can occur. They can have psychological symptoms and fatigue, and because of the joint involvement, they may lose their normal function. And as I mentioned, since depression is an important comorbid condition in psoriasis, flares may be associated with social withdrawal rather. So what does a flare look like? It's different for different patients. For example, if each line here represents a patient, a flare can be a huge change from baseline, but then the patient returns to baseline and then maybe later develop a smaller flare. The second patient here started a baseline, but after a flare, they get to a new baseline. They have another flare, a new baseline appears, and then somehow they drift down again, have a flare, and maybe get back to closer to baseline. Or in some patients, they just progressively get worse. So making the difference between what's flare and what's chronic disease may be difficult in this situation. So what can we do to help our patients prevent flares? There are, of course, the usual recommendations, the non-pharmacological recommendations that include maintaining exercise and physical fitness, a healthy weight, avoiding triggers. Many of these patients know that, for example, weather changes or seasonality can affect them and can give them a flare. And then it's very important to ensure that patients are aware of which medications they need to take regularly, and open conversations need to be had regarding their ability to adhere to the prescribed treatment. What do clinicians do when they examine a patient who experiences a psoriatic flare? There are several options. Some people may use anti-inflammatories, non-steroidal anti-inflammatories. Sometimes prednisone is prescribed for a short course. Or sometimes increase in therapy or change in therapy in order to meet the targets for disease activity should be done. So in conclusion, I hope I was able to show you that psoriatic arthritis is a heterogeneous disease, and that the assessments and various treatments need to be tailored to disease manifestations and comorbidities, and that assessing, screening, and managing comorbidities is very important for optimizing the long-term outcomes of these patients. And with that, I'd like to thank you, and I will be happy to entertain any questions. Yes.
If somebody has mild psoriatic arthritis, is that going to stay mild, or will that get worse over time?
It can get worse over time, and I think there are different ways of defining mild skin involvement in psoriasis. For the longest time, it was defined as people needing systemic therapy. More recently, we're using this body surface area. So if it's less than 3%, so just a few plaques, that will be mild, and they can be managed with topicals. All right, thank you.